Attention Deficit Hyperactivity Disorder, more affectionately known as ADHD, is one of the most prominent and one of the most controversial psychological diagnoses of the last 3 decades. The condition has been the subject of many heated debates within child development fields and is repeatedly accused of being overdiagnosed, underdiagnosed, misdiagnosed, mistreated, misunderstood, or simply of being unsubstantiated as a legitimate diagnosis altogether. Perceptions of ADHD are a diverse web of controversy, and I will not be picking a side today. What I will do is help you navigate that web, to better understand ADHD and its subdiagnoses, including ADD, ODD, and Asperger's syndrome. I will examine our understanding of ADHD, as well as each controversial aspect of it, to facilitate the informed decisions on this controversy that you can develop for yourself. So, first things first. What is ADHD? How is it treated, and why should we care? ADHD was first identified, though not yet titled, in 1902 by the British paediatrician Sir George Still. The disorder was described as an abnormal defect of moral control in children. It was a loose definition that could just as easily be paraphrased as bad behaviour, and was thankfully improved upon throughout the century. By 1987, the disorder had been officially recognised and redefined with a more specific criterion of diagnosis centred around 3 observable symptoms. The first is inattention, a difficulty with concentration, memory, and keeping on task. The second, impulsivity and over-emotionality, which would lead to poor decision-making and sometimes become an obstacle for socialisation. The final criterion is overactivity, constant fiddling, bursts of energy, hyperactivity, which when combined with the second symptom, impulsivity and emotionality, could lead to aggression. Not all cases present with this third observable symptom, and those without are subdiagnosed as ADD. After its officiation in 1987, ADHD gained traction as a popular condition with a trending diagnosis escalation that continues even now. Though whether a continued increase in rate of diagnosis is a good thing is a matter up for interpretation that I will return to later. ADHD is defined as it is titled. It is an attention deficiency and hyperactivity disorder. It is thought to be a neurological disorder, potentially genetic. Understanding of it is surprisingly limited, and there is still no empirical method to evaluate its presence or assist with diagnosis. However, once it is diagnosed, the method of treatment is well established. ADHD is treated medicinally, a solution discovered accidentally in 1936 by Dr. Charles Bradley, who observed the unexpected positive benefits of benzodrine on his patient's behaviour. In 1955, the psychostimulant Ritalin, or methylphenidate, was approved for production in the USA and has been the most utilised ADHD treatment globally since. The medication is objectively successful in fulfillment of its purpose, with trials indicating marked improvement in behaviour, though improvements are sometimes insubstantial compared to negative effects. Distraction, impulsiveness, emotionality, hyperactivity. As I return to the criteria for diagnosis of ADHD, I consider the dynamic of the controversy I aim to express and the influences it has, not just to our world, but to our local communities. We know the method of diagnosis, we know the method of treatment, but how does that affect us? Together, we are going to conduct a thought experiment and consider how they could affect a normal adolescent boy. There is a boy. His parents are getting a divorce. His preoccupation with his family's turmoil prevents him from concentrating in class. He is rebelling against their failure, and that has led him to behave recklessly in defiance. He might not sleep tonight. He will lie awake listening to his parents fight through the bedroom wall. He's so tired. That's probably why he's been so emotional lately. Maybe that's why he lashed out in school. Within that short story, the boy has fulfilled all observable criteria for ADHD. Though we know that his behaviour is the result of external circumstance, if his parents were to explain him to a doctor, he would likely be diagnosed. That would not have been such a significant problem if it were 1985, when the primary method of treatment for these issues was counselling. But after the number of ADHD diagnoses rose so significantly in the 1990s, the standard treatment became a daily medicinal stimulation with Ritalin. Counselling is recommended, but not prioritised, and in most circumstances the boy would do without, regardless of need. Additionally, there would be minimal benefit from the Ritalin, as the condition is not the source of his issues, though he would likely suffer negative side effects of the medication. These include anxiety, insomnia, stomach pain, loss of appetite and weight, nausea, vomiting, dizziness, palpitations, headaches, sweating, emotional instability, which ironically is one of the criteria for ADHD, and long-term susceptibility to substance abuse. This was a thought experiment, a hypothetical worst-case scenario. But when concerned with ADHD, misdiagnosis is inevitable. 1 in every 20 Australian school kids is diagnosed with ADHD, and prevalence of behavioural issues that mimic the observable symptoms of ADHD are on the rise in adolescence, attributed to energy drinks, poor diets, poor sleep schedules, and technology-based addictions. The ratio of children being diagnosed is expected to continue to increase, with government initiatives subsidising schools and parents with diagnosed students. As stated, a correct diagnosis can enable a child to benefit from needed medication, grant them access to resources to further development, and assist parents with identifying the issues they are already facing. But due to the lack of empirical evidence in determining validity, no diagnosis can be guaranteed, and the diagnosis and treatment of children with ADHD will continue to be a controversy.